Hello, this video is for radiologic technology students to learn the radiographic criteria of hand x-rays. So I have a PA hand here next to two obliques, the two different positionings of the oblique hand x-ray and a lateral x-ray. And this would be our routine exam. We would only be doing one of these obliques. You know, sometimes it depends on protocol where you're working or how you learn how to do those oblique hand x-rays. So we'll be talking about that in a minute. So really it would just be 3 images on a routine hand x-ray. So the first one is our PA hand x-ray to make sure that we demonstrate the joint spaces, the interphalangeal joints and the metacarpophalangeal joints open. We need to make sure that the forearm, the wrist, and the hand are all parallel with the IR. So we want the long axis of the hand placed parallel to the IR. The center ray for all of the hand x-rays and our routine hand x-rays would be a perpendicular center ray. For our PA hand, it will be at the third metacarpophalangeal joint, the third MCP. So what we're looking for in our PA hand x-ray is for the phalanges to be to look this as the same concavity on both sides for each phalange. So we want to look at the phalanges here and notice the concave curvature on the sides, on the shaft of the phalanges. So we'll be looking for a concave curve on the phalanges. We'll be looking to make sure that we've included the saw all the way to the soft tissue of that longest finger superiorly on our image, and then scan the image all the way down to make sure that we've included at least 1 inch of the distal forearm. And then when you're collimating, be sure to make sure that you've included all of the soft tissue of the first digit, the thumb there. That one sometimes gets away from us. Sometimes you might have to just move the patient's thumb back in. Sometimes they'll have their thumb sticking too far and you can just kind of move it back in without overlapping the soft tissue between the first and second digit. So be aware of that so that you don't clip the distal phalanx of the first digit there. So we'll also be looking for the metacarpals to be equal distance in between. So we want separation between the second and the third and the third and the fourth and the fourth and the fifth to be in equal distance, an equal amount of distance between each of those metacarpals as well as the phalanges. And we want to make sure that the soft tissue margins don't overlap here at the phalanges. The open joint spaces tell us that the patient's hand was parallel to the IR, it was placed parallel, and the proper central ray placement was used with a perpendicular center ray placement. Note that the first digit here, the thumb, lies at a natural oblique position and with our hand in a PA position, in a pronated position. So the thumb is actually lying at a natural 45-degree oblique on our PA hand x-rays. Now the next image we're looking at is the oblique hand x-ray, and this one specifically is with the phalanges nice and parallel to the IR. So we have this positioning down here showing you how they've used a sponge to help the patient to keep their phalanges nice and straight and parallel with the IR. In comparison, the x-ray right next to it, we can see that the joint spaces, we see a little bit of overlap here. You see the little opaque, that opacity there where it gets a little bit more white, bright and opaque is where the joint spaces are overlapping. We have the bone on bone instead of this nice clear black line that we can see on this image between the joint spaces. And that would be nice open joint spaces because the phalanges and the hand were kept nice and parallel to the table in relation to this positioning, where you can see that here the phalanges are actually making an angle toward the IR. The fingertips are touching the IR, whereas the palm of the hand, the metacarpals, are rotated 45 degrees away from the IR. So we still have that 45-degree rotation that we can see here on the X-ray, demonstrated by the metacarpals, but those joint spaces just do not look as pretty, so we could say that this positioning, the second image here, this is our, our most diagnostic imaging position for oblique hand, but, clinically you may be taught to do it in this way. So once again, the open joint spaces are about a perpendicular central ray being used, and the hand and the phalanges, the wrist, the forearm, all parallel with the IR. So body part placement along with central ray placement will show us a nice open joint space. Now, the sufficient obliquity of the hand would be a 45-degree oblique, and we measure that by looking at the space or distance between the metacarpals. So the way that they describe this is that we really should have no superimposition of the second and between the second and third metacarpals, but between the third, the fourth, and the fifth metacarpals, we can see the heads of the metacarpals superimpose, as well as the base of those metacarpals superimpose. But here, between the shafts, we can see a little bit of distance. We want a little bit of distance here. We want a little bit of separation at the shaft between those specific metacarpals. We can see a difference if we compare this oblique with the oblique next to it. We can definitely see a difference in the rotation of the hand, because by judging how close these metacarpals are, the third, the fourth, and the fifth metacarpals here, how close they are in distance, and then measuring the distance between the metacarpals here, between the second and the third and the fourth and the fifth, we see a little bit of insufficient rotation happening here because of the separation between the third and the fourth metacarpal. Once again, some of these things may be due to patient condition. Patient condition definitely plays a huge role in diagnostic quality of our images and how we see the anatomy in images. So, not being the technologist that did that X-ray or being there at the time, I can't really say, oh, this is a bad X-ray with insufficient rotation, because I wasn't there and I don't know the condition of the patient at that time. But we can, look at the metacarpals and see that this image here that's labeled B here compared to this oblique, that the second one here is not rotated as much. You can kind of see it in the carpals happening here at the carpals too. Down here in the carpals, you can see more overlap of the carpals here because the wrist is rotated more. Now this image doesn't quite meet our criteria as far as seeing all of the digits superiorly and then an inch of the distal forearm inferiorly. We don't see that. So, this is not meeting criteria in that. And also we've clipped that thumb. That's what I was talking about. Be careful about that thumb. Make sure that you're not clipping the distal phalanx of that first digit there on the thumb. So this was a good example of some things to watch out for when you're X-raying and then also evaluating your images for diagnostic quality before sending to the radiologist. Now the next image we're looking at is our lateral hand X-ray. We can, once again, we can go straight to those metacarpals and see that those metacarpals 2 through 5 are superimposed. This tells us that the patient's hand is in a true lateral position with little or no rotation at all. We look at the radius and the ulna to be superimposed distally, and we actually have to have an inch of the distal radius and ulna as well in this image, so we also want those superimposed. We want to be able to see those open joint spaces again. So one of our criteria of the positioning for this position, the fan lateral hand, is for their outstretched phalanges to remain parallel with the IR. If they are not, then those joint spaces will close up, much like we saw in this oblique position here. So, but we do see nice open joint spaces here, beautiful open joint spaces, identifying to us when we look at our image that the patient's hand was parallel to the IR, and we use the proper perpendicular center ray placement. Rotation-wise, we can tell that it is in true lateral because of the superimposition of the metacarpals and superimposition of the radius and the ulna. Also, we can see much more concavity on the anterior or palmar side of the shaft of the phalanges and the metacarpals. And then posteriorly, on the more dorsal side of the hand, the posterior part of our phalanges here, the phalanx here, we can see a more convex curvature of the bone. Convex curve means it's curving away from the midline. Concave curve means it's curving toward the midline. Now, I did not discuss that back here in the obliques, so let's just pop back over here to this oblique very quickly and just describe the rotation of the phalanges here in these obliques. With the obliques, we should say that we can see a more concavity on one side, that anterior side, than we do on the posterior side. And then we'll also describe that we can see 2 times the soft tissue margin on the anterior side of those phalanges than we do on the posterior side of the phalanges. And that's another way to judge our rotation on our oblique hand x-rays. I hope this was helpful. Thank you for watching.